already going over hypertension, then we'll do the concept blend. We'll start with
Wait. What PowerPoint are we on?
same one.
I never open it because I want you prepared.
But it's gonna be hypertension. I just need to make one, announcement, it's kind of like an advisement. If you have not taken a class that is scheduled in block 2, you need to take it during the summer before you go to block 3. For instance, if there's anything on the schedule and that is given along with your NUR classes, it needs to be completed, have been completed concurrently in this semester or over the summer. That being said, how many of you need more classes? Block 3, like micro, you can take it concurrently.
Oh, take that over the summer.
Oh, yeah.
You know what that with.
I have psychology that's supposed to be with this, but I already talked to Pfizer about taking it over the summer instead.
I'll get this under my All right, let's talk about hypertension.
Are we gonna have the thoracic aortic aneurysm?
Oh, no, this is block 2.
Okay, good.
That's why I said, we're skipping it. Just knowing about hypertension, let's go over some key things. What ethnicity has higher incidence of African American? And it goes back to some of the reasons, because one main reason Professor Thune alluded to it, when they do these clinical trials on medications, usually African Americans are not involved in those trials. There are some research studies going on now where they're going to different geographical areas in the nation where that they are trialing meds, including African Americans. That's why she says certain antihypertensives do not work well with African Americans, and we're going to talk more about it here. Okay. Hypertension generally is associated with a blood pressure over 140 over 90. However, some physicians want that diastolic to be even lower. What is the term for the difference between the systolic and the diastolic?
Pulse pressure.
What?
Pulse pressure.
Pulse pressure. Okay. And if you have someone who has systolic is it at rest or when we say systolic, what does it mean?
It's a contraction.
Contract. So you have your top number 140, but yet let's say this person, the heart and diastolic is at rest. Okay, that person has 110, 140 over 110. That is where someone has so much pressure and what blood vessel? Arteries, and therefore they're predisposed to what disorder? Congestive heart failure may be the reason why they have it.
PAD.
They could have, I'm looking at if the pressure is so great in the blood vessel, what's the major disorder? Aneurysm, CVA. And they may not have the perfusion that they need to the kidneys because of that pressure, or perfusion anywhere.
So, isn't the trend now really looking at diastolic as opposed to systolic, because that's the only relaxation you're ever going to have, and if your diastolic is elevated so much that you're actually at probably more risk than if your systolic was increased.
So the number, the difference is greater, you have lower pressure, and if it's smaller, you have higher pressure. Like if your diastolic is really high, the difference between
I think
systolic.
I'm hearing what you're saying. If the numbers are closer together, there's more pressure
Right.
predisposing them
Okay.
for
So
rest.
making sure.
It's a good indicator of developing CAD. You'll see on your charts, coronary artery disease, and that may be a factor for them to have an MI, a CVA, or you might have some renal insufficiency, or they may have end-stage renal failure. Now, we already talked about cardiovascular disease, and one thing about it with hypertension, it's symptomatic. That's why you probably heard it called the silent killer. People do not know that their blood pressure's up. Now, in my family, hypertension runs wild. I know when someone is hypertensive. And it's not textbook, but I know they're hypertensive because they'll get kind of flushed. Not everybody in my family has a darkened tone. All shades, not all shades of gray, but all shades of brown. And you can tell they can get flushed. Some of them, they say, I just don't feel good. My head aches. And I want to say, my head ache, so. But the thing is, you have questions back there before I go to
I was just gonna make a quick comment. When I was had triage in the ER last semester, this guy came in totally fine. He's like, yeah, I went to the dentist this morning. The dentist took my blood pressure. It was 220 over like 160 or something like that. And they're like starting him on all these meds, and he's like, I just thought I was gonna have a normal day today. I didn't know what's going on.
I had the same patient.
Asian guy?
Okay, let's digest to that. Knowing
Yeah.
what she said,
What ethnicity was
He
he?
was Asian.
okay,
Okay,
what
mine was
makes you
Hispanic,
think,
so.
what would the patient do if they started on medication? They would be the one to say, I feel good,
I don't need this.
I don't need my medicine today.
Yeah.
That brings me to a question that may be asked of you. Your patient states to you, oh, I feel so good, never felt better, I'm just not gonna take this medicine today, I'm just feeling so good. What would be your therapeutic response to that?
No.
No, you're not saying you're gonna die. You're gonna say that you need this medication to maintain your blood pressure and within norms for you. And the fact is with hypertension, you don't know when your blood pressure is.
Professor Denson, to kind of sort of answer Amy's question, his body can still compensate. So he didn't know that his blood pressure was that high because his body can compensate.
Eventually that would catch
That's when he has a big stroke, when your body can no longer compensate for the high pressure. In
What
the
is
stroke.
this disease?
Asian. They have a high
Let's
incidence.
go there too.
Really?
Asian. What in their diet predisposes them to hypertension?
Soy sauce.
A lot of sauce.
Yeah.
All right.
Like all they eat is soy sauce. They eat other stuff.
That's not right. Yeah. Oh, she has a question. Uh-huh. Guys, let's what she said is her mom was on cold therapy for hypertension, 2 meds. One med, they said, go ahead and take. And it was probably an ACE inhibitor or whatever those ones was. And then another one, they told her to not take. And her blood pressure was what? Okay. What could they give her that is not a blood pressure med to bring her blood pressure down?
Diuretic.
So maybe that was what they held off.
Okay, so we'll try the what's normal for you. If someone's normal blood pressure is like 200 or over 100, that's still not healthy.
It's not healthy.
So what is the deal with that then? Because like if someone's like, oh, that's what my blood pressure always is, that's still not just because it's normal.
You need to educate them on the fact, let's go, someone's going to surgery. You don't want that blood pressure to go too high, a certain analgesic, anesthetics will make it go higher.
Right.
So, a lot of times
So you
before
would still
surgery,
medicate them, right?
you give them with a sip of water, their medication, physicians have seen.
But like in general, like they
In
would still
general.
put them on heart. Like,
Now, what happened with her mom, it was the physician specific. But rule of thumb now is you'll see a lot of patients that the anesthesiologist, or if they're going for any type of testing that are on the cardio unit, they'll say give meds with a sip of water, because they don't wanna get a false reading. They don't want an adverse effect. Yes.
And a medication that they would use instead of like the ones that we're teaching you guys is called hydralazine. It's IV and it works on the arteries. So it can lower the blood pressure, but safely, more so than if we gave them like a beta blocker or a diuretic. Sometimes you want the blood pressure to be just like in the case of your mom, that probably was a safe level for her depending on what procedure she was going to have. But if someone is going to have surgery, do you want to give them a diuretic?
No.
Okay, so we pump them up with fluids to give them that fluid volume because you need that during surgery because you're going to estimate some kind of blood loss. But if that fluid volume makes their blood pressure go up, we still need the fluid volume, right? So we'll give them some hydralazine, I think I'm saying that right. Yeah, hydralazine.
Is it a vasodilator or?
It works on the smooth muscles of the arteries. So you may see that on your patient's mark, along with other medications.
Okay, the goal in treatment is to reduce the blood pressure to prevent major organ damage. So, when someone's hypertensive, we want to lower that blood pressure so that you don't have a major, with the brain, a stroke, with the heart, an MI, with the renal. There have been patients who have not monitored their kidneys, not kept up with visits to the physician, where their kidneys just don't give perfusion. You don't know it till they're in complete renal failure. Also, major organs. If someone has hypertension, then you do a chest X-ray, which will show you the morphology of the heart. If this person is not managing or has not seen medical attention for their hypertension, what condition of the heart might you see?
It'd be big.
The heart's having to work hard. Okay. We try to be preventative and not start with medication all the time. So there's some lifestyle changes a person can do. What are they?
Lose weight.
Stop smoking. Weight reduction. Huh?
Exercise.
What you saying now, Sharon? Dash diet. Dash is something. Okay, so diet. Stop smoking.
Stress.
Reduce your stress as much as possible. You can't change your gender. You can't change what family you're in. Sometimes you're really good. So. Would a single blood pressure reading dictate that someone has hypertension?
No.
You want a series. And you want it not just upon arriving. You want it different times during the day, so that person will have a little diary, so to speak, that they'll tell to the physician or report to the physician. And from there, we can determine if this person is hypertensive. When you go, there are sometimes a person can be diagnosed that there might be a correlation of having hypertension when they look in your eyes. What will they see? What will the ophthalmologist see? No.
Like big
What will the
muscles
blood
in their
vessels
eyes.
look like in your eye?
Be enlarged.
Dilated. they'll look in the back of the eye, or they'll look at all this back twitcher, and they may say you need to check with your primary physician to see if you may have some hypertension when they look in your eyes. If, relative to this slide, if a person does not reduce their blood pressure as a result of weight loss, stopping smoking, reducing their stress, within, usually it's 1 to 3 months depending when you're going back to the doc. The thing is they will start pharmacological agents. Some of those pharmacological agents, you have, what if I had this person on name me a calcium channel blocker. What are they in? Fine. So nifedipine, which is Procardia, nifedipine, P-I-N-E, that's a calcium channel blocker. Brand name is Procardia. Okay. Name me one that is an ACE inhibitor.
Lisinopril.
Lisinopril. Okay.
I know that one.
When you give someone an ACE inhibitor, what are you preventing forming that would keep their blood pressure constant?
Angiotensin.
You're saying, yeah, you're preventing it converting to that. Let's say you're going to give this person an ARB. What is that?
Sart.
Angiotensin receptor blocker, I believe it is. Okay. Let's see.
Sart.
Okay. Why might you give them a beta blocker?
Slows everything down.
Which ends in what? OL.
Oh.
You want to increase that contractility, thus it will bring that blood pressure. Now, with hypertension, some people are not just on one med. So if you see a patient says to you, why am I on 2 medications? What might be your answer? They're working together. What's the term when they're working together? Synergistic. They're working together to increase that blood pressure. Synergistic. What else? Why might they give a diuretic? What would be the purpose of the diuretic? With any of your blood pressure, your antihypertensive. What does diuretic do?
Lower the blood volume.
Yeah, it lowers the volume of fluid. If it lowers the volume of fluid, and let's say it's Lasix, or it could be hydrochlorothiazide, which is a diuretic. It's HCTZ. You know they're on that. With the Lasix, you're going to be monitoring the potassium level. Hydrochlorothiazide, you're losing fluid. You watch the potassium. Also, what might your patient say to you if that would correlate as to you thinking as the nurse that they have increased potassium?
Muscle cramps.
Cramping in the legs, stomach. What might the heart do?
Dysrhythmias.
Dysrhythmias.
Dysrhythmias. And they might, if that heart is compromised, they might have some chest pain. What might it look like on the EKG?
ST elevation.
Okay, so one for my clinical. Did you bring that little page for me?
Oh, I think so. Let me find it.
Just kind of pass it around.
Yeah, I gotta see if I brought it.
She had a patient, or they were failed of seeing the EKG pre and post.
No, I didn't bring it.
Okay.
I have my care plan.
Anyway, this person actually, the California worker, this person had it up where this person was STMI, which is ST elevation MI. It showed it elevated, and when they did the cardiac cath and put in a stent, it showed that the T wave was still elevated, but that person's confusion, was increased because it almost looked like no one's not good. So, you guys who are with the clinical, that makes me feel better. So, getting back to where we were, there are avoidance of smoking that we talked about. Modifiable changes, you need to know modifiable changes, diet, which is dietary, exercise, okay, pharmacological agents, we kind of hit upon some of those. What you need to teach the patient about those pharmacological agents, safety-wise, and what you need to monitor in regards to labs. You need to be alerted to the fact that that patient needs to take these medications until, upon doing a diary again, their hypertension resolves. They have to wait, because there are people who have had weight loss and they no longer have hypertension. And the step care approach is just saying, you start with modifiable things, diet, exercise. Okay, relative to diet, what foods would you include in your diet? What does it almost look like that you see served to patients? It almost looks like an ADA diet. You want them to reduce their cholesterol type foods. You definitely want to reduce sodium. What are some foods that are in low in sodium? Vegetables with not
Fresh.
bad in salt.
Fresh foods.
If I had to choose between tomatoes and or celery.
Celery.
Sorry.
Celery. There's a high content of sodium.
Yeah, huh?
Tomatoes? Potassium, yes, potassium. Okay, maybe I'm thinking what was put on it. I'm glad you guys, you're listening. You're listening.
I was saying like tomato sauce. That's got a lot of salt in it.
Yes, yes. So, let me just clarify this. What is tomatoes high in? Like, huh? Like, something we said.
Vitamin K.
Ramsey said it.
Vitamin C.
Vitamin A and vitamin C. Okay. Now, what food do people eat? And it's not fried, but a potato. A potato has a lot of what in it? Starch, which turns to what?
Sugar.
Sugar, which affects the plastic. Okay. All right. So the first approach is modifiable. Then we talked about the pharmacological agents, all of the above, calcium blockers, diuretics, ACE inhibitors. And once the physician, through follow-up, once the physician sees that patient is therapeutic with certain meds, they stay with those meds. And it can be combination. Here again, physician will ask the patient, or you as a nurse must ask, what changes have you made? how you feel about the changes you've made, be it dietary, exercise, compliance with med administration. And what is that position preventing to occur? Remember what the goal of hypertensive, anti-hypertensive therapy, what is the goal? To prevent injury to what?
Major organs?
Major organs, the brain, the heart, the kidneys. Okay. What are some ways of reducing stress? Let me choose.
Yoga.
Well, it has to be age related. Let's say y'all. Exercise to reduce stress. What? Who said that? Oh, yeah, hey. Reduce stress, what else?
It works.
Okay, TMI. Okay, what else? Exercise, period. Exercise, relaxation, going to a quiet room, have times for yourself. Movies. Okay, all the above, whatever helps you reduce stress without adding another problem. It's not going and throwing down a few beers.
I was gonna say.
Because if you throw down a few beers, what does it do?
I thought a few was okay.
What's few to you, like not me few to somebody else. What does that, okay, alcoholic beverages, how is it contrary to therapeutic
Wine.
Wine
should be diuretic. It should be good for you.
Now, some people take wine for dinner as a relaxation thing. Tell them how much they drink. Don't drink almost half a box of
Come on now, that's.
Well, I've been to some elderly people home. I know I'm digressing. I've been to some elderly individuals' homes, the little ladies, and I'm not into the alcoholic stuff or drinking or anything, but she had some beverage called Franzia.
That's not.
She had one on her dinner table, but I kind of, because I did a home visit, I went in and she had other boxes
They stock that stuff.
in her cabinet. So that was relaxation for her. She was relaxed too. All right. Okay, she asked a question. Okay. She's saying if alcohol causes a diuretic effect and your Lasix helps it, but you with the alcohol, it's getting the diuretic effect. But why do we want to prevent them from taking the alcohol? What? It can,
Fix your liver.
yeah, you take too much. But what other things does alcohol can do?
Raises your blood sugar? Go on, doesn't it?
Intensify the medication.
Oh, I've seen it, I know.
Huh?
I get it all the time.
Okay,
Liver?
think about alcohol.
It causes
It
weight
causes
gain
all
for
other issues if it's taken in too often. Like for instance, yes, it can cause judgment,
malnutrition, weight gain.
malnutrition. Okay, it causes other issues, that's what I'm saying. Because it's a diuretic effect.
Can we tell?
Well, the doctor,
And die.
what medication would they be taking to reduce the cholesterol?
The statins.
Lipitor, all of these.
Or vitamin D3.
Okay, which is?
Niacin.
Niacin.
ICU. But the problem is they go to ICU because we want to reduce that blood pressure to prevent all of this damage. Okay, now, let's change gears. Start with the questions. We have 30 minutes. She will present concept of it. And she'll explain how we do it, and then I'll go into mine. What am I doing? Concept learning. Concept learning.
Okay, what do you want to know? I can't do it. Alright, the way we do concept learning is basically we just let everything together, we make it work, we make it interconnect. Because your test questions are not going to be like easy. Yeah.
It won't be, you gave your case of laces, what electrolyte are you going to use?
Yeah, probably like that. Some questions might be that straightforward, but it will be disguised very well that it will be that straightforward, you know what I'm trying to say? So it won't be like your patient is taking laces, and then you got that answer to choose from. There are gonna be other things in there that may distract your thinking, but the answer will be you need to monitor their potassium. So,
Which might be, it isn't, but it might be on another test, somebody else's test. Your patient is on diuretic therapy. They are experiencing cramping that started upon arising. What electrolyte will you be monitoring on this patient? You gotta know what electrolyte causes cramping.
and that they're on diuretic. Or you may not even have, you may be given just the name of a medication. And you need to know what that medication is, how it works, the side effects. And depending on how the question is worded, you may need to know if it's therapeutic or not. You may need to know, bad values that you need to be aware of. You may need to know what other orders you need to anticipate in conjunction with that medication. So, what have you heard about this person?
Nothing.
I heard there's a lot of info about the heart on there, not so much the.
Maybe not. I don't know.
Depends on what
Depends on.
Heard it's difficult.
I mean, I don't want to lie to you, be like, oh, it's so easy. Huh?
Why are you doing this, guys?
No, we're trying, what she's doing is we're not giving you like, oh, it's so easy, and then you go into your study and you say, breathe. But let me just address to you in regards to meds. We said there's gonna be meds. What have you heard relative to her? You know you need to know those meds that, the beta blocker. If you know one, you know the rest. What is a beta blocker? What does it begin, what end with?
OL.
Okay, it blocks that force. But what's the side effect of that med? It lowers your heart rate.
Not seeing
And it's a,
That won't be no nausea, vomiting, that's the side effect.
now, you have a calcium channel blocker. What do you expect that to do?
So whatever.
Cardiac workload will go down.
It decreases the calcium being channeled over, so it decreases that contractility.
Which one can give you the AV node block?
It's in a calcium channel.
Yeah.
Beta
Beta
blocker.
blocker lowers your heart rate.
How does the beta blocker? So you're telling me you know that it all of them do what? Lower your blood pressure, right? But you need to know how. So let's start with wrong medication. Your nitrate. How do they lower blood pressure?
Dilates the coronary.
Okay, so they vasodilate, right? What is an expected side effect of your nitrate?
Headaches.
Headache. Okay. How many nitro can you give within 15 minutes?
3.
Okay. how should someone keep their little tablets?
Out of the
In the
sun.
original package.
Yeah.
Or bottle, what else?
Out of sun.
Out of where? Out of sunlight, what else? Not who?
Make sure they're
No, not in candy dishes.
not old or all crumpled together.
Okay, it should be, dry in its original container, kept away from sunlight, and they should watch what kind of date on there. Expiration, because we don't want big clump of nitroglycerin, we don't want them to put that under their tongue, okay? One thing I kinda alluded to it, is that we can do IV nitro, but it is, micrograms. So it's weight-based and all of that stuff, and so you might see something like this on your exam.
Rob,
Like,
This will work for any of your cardio. Let's say you have a person that weighs 60 kilograms. I'm not gonna have you convert from pounds to kilograms, 60 kilograms. The physician ordered 400 micrograms of NCG, 400 micrograms per kilogram per hour. Okay? You have provided 30 milligrams in 250 normal states. 30 milligrams in 250 normal states. So, I work it this way. You want 400 micrograms. But what do we need to do? How is that supplied in that, bag of solution? Milligrams. What do we need to do to have light over light? How many, micrograms is 30 milligrams? 30,000. Now, if you do it this different, whatever, do your thing. Do the Burger King. Have it your way. What is it in? Okay. Okay, you want this, you have this, and it's just asking how many milliliters. This is what you're gonna get per hour. 400 micrograms per hour.
Per kilogram or no?
Per kilogram.
So you
But I'm just asking you, if you have this many disorders, this is what you have. That's per hour. And you have 250 milliliters. Do the math. What does it come up to?
did you say you already gave him 30 milligrams? Or
No,
that's what
you're
on?
gonna give him 400 micrograms. Okay, but what did I miss?
wait.
The weight. So, $60 kilograms. You want 400 micrograms per 60 kilograms. Okay, so you're gonna have to take the micrograms per kilogram,
It's 24.
multiply, that per means multiply, over,
Isn't that 30,000?
yeah, because 30 is 30,000, because if you have 30, what is the relationship of micrograms?
Yeah.
To milligrams. Is everyone clear there
Yep.
as far as,
Mhm.
if you have 30 milligrams, that's 30,000 micrograms. We were missing this because we want 400 micrograms per kilogram. Okay, now you have all what you need. What does it come to per hour?
200 million.
Okay. Now, it could be 40 micrograms. That would, it would be less. But you say 200 mils? 200 mils? Yeah. Okay. It's probably not gonna be 100, but I did this to show you If it looks funny, it's probably funny. You want to question the order. But generally, they might have 40 micrograms, and you have per kilogram divided. And you gotta always, the key thing with these problems is, usually it's delivered in milligrams, and you gotta turn that into a microgram base. You have your weight in kilograms per the number of micrograms, and what's in the bottle. Desire over what you have and the quantity. If you do it differently, go ahead, have it your way.
As long as you come up with the right answer, that's all we care about.
While I'm at it, talking about it, heparin is set up the same way. How many units per hour by what you have, by how many milliliters. That's what your, how many milliliters per hour. Heparin can be asked another way. You have the rate per hour, 40 milliliters, but you put it over how many milliliters you have, times how many units in that whole bag of solution. So go back to your notes. It's not, there's 5 math. I assure you there will be a heparin or 2. There will be one of these. But I'm not going to make it a hard one of these because we're not in block 4. I might even ask, how many micrograms will you be giving this patient based on an order, which will be whatever the physician orders per hour times whatever the kilograms. So you just multiplication. Now, so you'll have a heparin, you'll have one of these, and you will have a what?
It may be some dosage problem we need to
Yeah.
figure out. It may be a EV conversion problem. It's really what people up.
What conversion? The metric.
It's a conversion. It's convert. So I don't know, but you know the math. You see it, you do it. Alright.
And that reminds me, relative to math, probably by the end of next week, in preparation for your math test, I'm gonna have a practice, on Blackboard where you can take it time and time again.
When did
I'm
we
having
take
class.
last
It's later down.
I think it's like week 13.
And you'll have plenty of practice.
Interdimensional.
Okay, go ahead.
Alright, so with that, what do you want to do before you give nitro? Check the blood pressure. And after you give nitro, you want to
Check.
Okay, we kind of talked about all of your beta blockers. How does it lower the blood pressure?
Blocks the beta
Okay,
cell.
so blocks the beta, is it 1 or 2? What's in the lungs? 1 or 2? 2 are in the lungs. So beta 1 are in the heart, right? Now that I told you that you have beta cells in the lungs, what must you monitor your patient for to be given the beta blocker?
Respirations.
All right, what's going to happen to those? Why? What's happening? Bronchial constriction. Okay. So if it blocks the beta 1s of the heart, we talked about parasympathetic and sympathetic. Which one is the
Sympathetic.
Okay.
Why is it sympathetic if you're slowing it down?
It's blocking
Oh,
it.
it's blocking sympathetic, got it.
What do you want to teach your patients if they are taking any of these medications? It's kind of universal teaching, right? What do you want to teach them?
Don't
Rise
start
slowly.
Okay, so don't rise abruptly, don't stand abruptly. What else do you need to tell them?
How to check their pulse?
Okay.
Don't
that's it.
stop taking the medication.
Don't stop taking the medication abruptly. What else would you like to tell them? Are they a fall risk?
Yeah.
So what else do you teach patients who are fall risk? If they're in the hospital, they need a call light. If they're at home, where? What? Okay, move all those grow bugs, all the clutter, well-lit areas. What else do you need to do to them? Huh?
Bedside commode.
Okay, if they can't have a bedside commode, what do you want to do to that bathroom?
Make it safe for them.
What did you say? Make it accessible. How? Handrails. If they don't have a bedside commode, what can you do? I'm a short person. What do for me? Raise toilet seat, okay? Because if I get down low and I'm taking 3 or 4 blood pressure medications, you're telling me to ride slowly, I can be there all day long, right? ACE inhibitors. How do ACE inhibitors work?
Block
Block the
angiotensin
angiotensin.
The brain and so-
Okay, so stop 1 from going to 2. What lab values do we need to use?
BUN
Why potassium?
because it excretes. The kidneys excrete it.
What do the kidneys excrete? If we're blocking 1 to 2,
Sodium.
sodium, so we're keeping our potassium. Why else do we want to look at our BUN and creatinine?
They're excreting it properly.
Where does this work? Works on the kidneys, right? Okay, so this one is specific to the kidneys, where everything else kind of works around the heart, all right? So this is kind of like the odd man out. It works on a totally different system, but it makes sense because how much of our cardiac output goes to our renal?
25.
25%. What are some common side effects from someone who takes an ACE inhibitor? What else?
Could get the cough.
That dry cough. What else?
Tachycardia.
Angioedema, tachycardia. And we want to monitor that those kidney and the potassium. Your calcium channel blockers. What's so special about those?
Just slow down the
Contract.
contractility.
Okay, slows down the contractility of the heart because it does what? Blocks what?
Calcium.
All right, so all those happy-go-lucky calcium that are just jumping across that membrane, we kind of block those, right? What is the exception to the rule? Still tight as them. It does not end in what?
PIN.
All right. What are you going to monitor your patient for who are they're taking a calcium channel blocker? Okay, calcium levels. What else? A dysrhythmia. What else? Shortness of breath. If we're doing what to the blood pressure? So we want to monitor them for blood pressure. All right. All these are blood pressure medications. For ARB, what do they end in?
Sart. Tan or
Okay, your tan. What's so special about a certain ethnic group and your ARB? What about African Americans? Right, it only works in conjunction with another medication, all right, whatever that may be, be it diuretic, it could be something else. So if you have someone of African American descent that's just on an ARB and their blood pressure is not being lowered, then maybe we need to look at adding something else. How does an ARB work?
blocks aldosterone.
2 for going to
Aldosterone.
aldosterone, so where does this work?
Adrenal gland.
Yeah, okay, it's the renal thing again, right? So what are we gonna be monitoring? BUN and creatinine, we wanna make sure our kidneys are working before we start handing out this kind of medication, all right? What else do you wanna monitor?
Blood pressure.
Okay, our electrolytes, right? We wanna monitor the blood pressure, works on blood pressure, okay? So see how something's so easy as blood pressure, you guys keep forgetting that's something you always wanna monitor when you give that medication. Don't forget the simple stuff. Why do we give aspirin? What does it do? Antiplatelet. It prevents platelets from what?
Activating.
Aggregating, so from clumping together. Side effects of aspirin?
Bleeding.
Bruising. What else?
Burn out your body.
Who?
GI disturbances, ulcers.
GI disturbances. What else? Say it louder. Tinnitus.
Oh.
Don't forget that, okay? Tinnitus. Aspirin causes tinnitus. What about your Plavix? What is that?
The
Plavix
statin.
and Ticlet. What are they?
Statin. Aren't they?
Antiplatelet. What do they do? How?
clever.
Well, can I suggest sometime you go back and you review these medications? Because your patients, you're giving these meds, right? In a hospital? So I'm gonna need you to know what you're giving, and why you're giving it, and what to do, and why you're looking for these things, and how you're supposed to educate the patient, right? So if you don't know what it is, how you supposed to educate the patient on what it is?
And I'm gonna guide you some way. There's a difference between aggregation and activation. Activation. Remember the inflammatory response? That's what titillate is.
Heparin, what's so special about heparin? Prevents what?
Prophylactic.
Prevents formation, okay? What lab would you like to know about?
PTT.
All right, which one of those is specific to heparin?
PTT.
All right. What about your thrombolytics? What medication is a thrombolytic? All right, your
TPA.
TPA or your Resiplex, whatever it is. What's so special about that? All right, that busts the clot. It dissolves the clot. Where heparin does what? Okay, prevents the clot. What's so special about an MI? There's no such thing. I hate this on the news. They had a little heart attack. They had a little stroke. The difference between little and big is that they're still alive. Okay? If you have the big one, usually you're not going to make it, or your quality of life is going to be very, very, very poor. So a heart attack is a heart attack. A stroke is a stroke. Why is it called an MI? Tissue death. The tissue's not getting what? Oxygen. Because why? It's occluded usually with what?
Plaque.
Plaque. And what is plaque made of?
Cholesterol.
Lipoproteins and what else? Cholesterol. Okay, so remember that little thingy we saw about how the plaque forms and how it occludes the artery, not in the artery itself, but kind of in the cell, the lining of it, the wall, and it causes this. Why do we need to get people to the cath lab?
Open it up.
Open it up. Time is what? Alright, so the whole purpose of getting somebody to the cath lab is to open it up to get perfusion, right? So before they go to the cath lab, what are you going to do as a nurse? Okay,
Baseline
give me 4 hours. What else?
Vitals. Baseline vitals.
Baseline what? And what else? Why y'all stop at vitals? Baseline what else?
Labs.
Baseline what else? What did you say?
Pressure.
Assessment. I want you guys to get in the habit of when we say, what are you going to do as a nurse? The first thing you're going to do is assess your patient, okay? I don't care about vital signs because if I can look at you and see you're not breathing, I don't need to stand there and count your respirations, okay? The first thing I want you guys to get in your head is you are going to assess your patient. So your baseline assessment. Now let's move to baseline vitals. What else do you want to get? Labs. What kind of labs?
Cardiac enzyme.
Cardiac enzymes. What else?
Clotting.
Okay, so your coags. What are your coag panels? Alright, these answers don't change. PTT, PT, INR. What else do you want to get?
Mucus scan.
What?
I got that off the other notes. Mucus scan? For an MI?
Oh, no, we're not going to do that. What other labs?
Troponin.
Okay, that's part of your cardiac. You told me cardiac enzymes. Troponin. What else is in there? Myoglobin. What else? Okay, your CKN,
CKM.
CKMB. How do we know that they've had a heart attack based on those labs? Which one?
Troponin.
Troponin. All right, troponin is your key indicator. So we have our coags, we have our cardiac enzymes. What else do you want?
EKG.
CBC. What else?
EKG.
Electrolytes.
What's in that? What did you say? CMP. Okay, when we ask for labs, they don't change. So your CMP, your CBC, if they might be having a heart attack, let's throw in some code, your cardiac enzymes. If we're doing anything where we may have the potential to give them something blood related, then you're gonna do your coags. In that CMP, what's in there? So don't tell me you're gonna do a CMP and I'm like, well, what's in there? You're like,
calcium.
Electrolytes, what else?
Creatinine.
Okay, your BUN and creatinine, what else? Glucose.
Albumin.
What's your liver enzymes? Yeah, your liver enzymes.
ALT.
Proteins and albumin, all those things are kind of like add-ons. All right, so get familiar with what's in there. So we have all of our labs done. What are we assessing for before they go to the cath lab? If they're able to, how do we know they're able to clock before we do it? Okay, so we looked at our labs. What else? What do they do in the cath lab? Allergies. What about those allergies?
The iodine.
All right, so your iodine and shellfish, what do you want to assess? Why do you want to put your hands on your patient? What are they going to do in the cath lab? Invasive. Where? Thank you. We want to check those peripheral pulses, don't we? And how are we going to check them?
Same time.
At the same time, symmetry. So if they go in the arm, we need to make sure we assess all of our upper extremity. We want to assess our lower extremity. They've been NPO for 4 hours, hopefully. If not, in my world, they don't have the luxury to be NPO for 4 hours. So we're just going to send them to the cath lab. If you are the nurse on the unit, yes, then they'll go hopefully the next day. Sometimes they send them straight from the unit. When they come back, what are you going to assess them for?
Same things.
Which is what?
Bleeding.
Okay, pulses, bleeding. What do you need to monitor as far as bleeding? What's going to be on that site?
Dressing.
A pressure dressing, maybe even a sandbag, or they do this gel stuff now that they put on there. What are you looking for around that site? Edema. Edema. Is a little edema good?
Yeah.
Is a little bruising good?
Yes.
When are we concerned? When there's clot. Okay, so you want to kind of look at that. What is that called? That's sitting right there. Hematoma. So we're going to look at the size of that hematoma. Would a little oozing be okay?
Yes.
All right. What you don't want is if you take off that sandbag and it throws up at you, okay? Blood comes everywhere. What else don't we want when we do our assessment?
Look at the C-pole, so you have to turn them. We went to the cath lab and they said we have to turn them to make sure they're not bleeding behind.
Behind. That's right. Because they're laying down, right? Everything is kind of dependent and it falls back. So yes, you can check that. You said something else. Okay, so they need to lay flat, right? Who likes to lay flat still? Nobody. All right. What else are we looking at or feeling for? Fetal pulse, temperature. What else are we looking at? Perfusion. How do we know they're perfusing? Cap refill. What else? Pulses.
O2
Color.
Temperature.
Temperature. So even if I take those covers back, what should I see? Everything's right in the world. What do I see? Same size, same color. If I touch them,
Warm.
warm. Fetal pulses. All right. Something else I want you guys to get in the habit of is your eyes. Okay. Before you touch somebody, you have 3/4 of your assessment done by looking at them. Okay. You can look at their color, right? You can look at them and pretty much tell if they're cold or if they're warm. They're going to be diaphoretic. They're going to be cyanotic or ashen or something like that. You can talk to them. If they can carry on a conversation, then they're confusing. If they're having a lot of difficulty wrapping their brain around, if that's not their baseline, then something else is going on, okay? Who meets a chest pain patient at the door?
Mona.
Who is Mona?
Morphine,
Morphine.
oxygen, nitro,
Aspirin.
Why are we giving morphine? And what else?
anxiety.
And what else? Smooth muscle
Relaxer.
relaxer. Morphine's awesome. Morphine does a lot of stuff. Oxygen because
They aren't getting
they
it.
don't have it. All right, so we have to give them some oxygen. Nitro because, all right, and aspirin too. All right, so there, you walk into the room. The patient is complaining of chest pain. What is the first thing you would like to give them?
Oxygen.
Oxygen. All right, now we got that part done. Now let's put them on what? Let's put them on a monitor. Let's see what we're working with. If they're having a heart attack, what is that PQRST gonna look like? ST elevation, okay? So we have them on a monitor, we gave them oxygen, we have them on a monitor. Can we have the potential to give them medications? What would you like to do before you give them medications?
Check the blood.
Okay, check the blood pressure. Blood pressure is fine. You're gonna give them one what?
Nitrate.
And you can give that sublingually, how long?
Every 5 minutes.
One every 5 minutes for a total of
3.
in 15 minutes. Correct. And then we'll give them how many milligrams of aspirin?
325.
And how should they take that?
Chew it up.
Okay, chew, not swallow. Different types of chest pain. What are the names of them?
Stable, unstable, variant,
Intractable.
atypical, mild.
Atypical, yeah.
Yep, and post MI chest pain. So kind of go back and review those. Who starts off this whole heart beating thing? Who's in charge of that?
SA node.
The SA node tells who?
The AV node.
The AV node tells who?
Energy fibers.
All is right in the world. The SA node is working. Our heartbeat is what?
60 to 100.
If the SA node decides to go on vacation and the AV node is working,
40 to 60.
and if the SA node and AV node went off to Cancun and left the tissue fibers at home,
30 to 40.
40. Are we very concerned about that?
Yes.
What does our patient look like? Oxygen
Right.
deprived,
Shortness of breath.
shortness of breath, confusion, they
Tachycardia.
may be, are they gonna be tachycardic?
Oh, no,
It's gonna be bradycardic, okay? Our blood pressure is gonna be what? High.
Low.
It's gonna drop. Are we perfusing?
No.
So if we're not perfusing, now let's think about this preload afterload thing. Where is all the blood?
Back in.
In the periphery. So if it's in the periphery and it can't get back to the heart, somewhere, somehow, our pressure is going to start to drop because we can't get that fluid volume back to circulate where it needs to be. They may start out hypertensive at first, right? Okay, because the heart realizes something is wrong, but it doesn't have all the working members to keep it beating that fast. All right, so it's going to slow down. The blood can't come back where it's supposed to be, so it's going to pool in the periphery, and our blood pressure is going to drop. All of this makes sense.
Now,
This part of the room is like,
now,
this part is like,
based on all what was said, you need to ask yourself this. What would my patient say? What would I see? What would I elicit from the patient that would let me know they understood my teaching relative to their medications? What would make me think that, hey, this person knows what's going on? And there's going to be choices that is going to alert you to, they don't know what's going on. Or they do know what's going on.
oh, so not that. Women and heart attacks, what do you know about them?
They present very differently.
Okay, what do they say?
They don't feel good.
What else?
They don't-
Fatigue, tiredness, okay? Anxiety. They're not gonna have that crushing chest pain. What other population may not have that crushing chest pain? Diabetics. Why?
Neuropathy.
Neuropathy. We talked about your diuretics. You have your potassium wasting, you have your potassium sparing, diet, all of this kind of comes into play. Everything that Professor Benson and I talked about kind of go together, right? When she was talking about hypertension. So remember your diet teaching. Remember your family teaching. If the patient says something to you, you need to validate that patient. Don't turn them off to somebody else, okay? So if you ever have a question where the patient says, I feel like I'm losing my mind, and one of the responses is, do you want to talk to somebody? Yeah, I want to talk to you. But that's not your answer. You need to validate whatever the feeling is, right? And then you carry on from there. So, I understand you feeling that way. Yeah, did you validate them? Are you going to solve their problem? No. But you validated that person. Everybody wants to be validated, right? So if you ever get one of those infamous psychosocial questions, And it's kind of sort of like that. Anything psychosocial, just validate the patient. And people will, then you say, I understand. Would you like me to get somebody for you to talk to? Okay. Make sense? Are you scared?
Okay. It's five after, I'm gonna do 10 minutes going over what I had from the prior lecture. The one thing you need to remember about, your, anemia, there's fatigue, there's having some degree of shortness of breath. Fatigue and some degree of shortness of breath. Now, when you go through the body, if they're anemic and do not have enough red blood cells, you know the red blood cells within our erythrocytes do not have, for some reason, there's not enough of them, so you're not getting enough oxygen, but they carry the oxygen. And the iron carrying capacity, that's why they're fatigued. The difference, to help you, this look red, aplastic, the bone marrow is not producing enough of your blood cells. And it's caused generally from some type of chemo or radiation. And around here, it's probably insecticides. What you're gonna do about it, these people, if it's bone marrow is the problem, they may need, I didn't talk about it, but if it's not producing, they may need a transplant. But that's the difference of aplastic. Now, I'm gonna go to another one that's different. That would be pernicious anemia. What would they be complaining of?
Numbness.
Tingling, the paresthesia. They may have the other stuff that we talked about that's universal, but they may specific, if the person's having the tingling, you'll have choices of anemia. You know it's pernicious. They don't have that entrance back. Okay, now let's go back up. If someone's iron deficiency anemia, what are they gonna get? Iron replacement. If it's given oral, what would you tell the patient they're gonna experience?
Constipation.
Staining if it's liquid, if it's an oral pill, and if the oral may be a liquid, what happens in the GI?
Goes down.
Constipation,
nausea.
there may be constipation, cold stool, 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 and they may feel that it may be blood. If you thought it was blood, what could you test it with?
Whole blood test.
Stool sample for quiet, okay? Folic acid, that's a dietary thing. And we talked about someone who's taking oral contraceptives, it interferes with the absorption of folic acid. Or decreases the effects of the oral contraceptive. Okay, relative to iron, going back here. If it's IM, what root is it?
Uterine.
What are some foods rich in iron? If a person does not eat meats, it's beans, okay, green, leafy, spinach. Okay. Some of the people who are high risk is your pregnant women, your adolescents, because of the rapid growth, the needs. Okay. Sickle cell anemia. The problem with them, they don't have enough capacity because the cells are sickled. The problem with them is they don't have the capacity for iron and oxygen, and those cells come together. When they come together, what's the problem there? Blood clots that decreases the perfusion to organs. What throws them into crisis?
Change in weather.
Dehydration,
Stress.
cold weather. It's genetically acquired. These individuals, when they come to the hospital, they need oxygen. But if they're complaining of pain, and you know you need to get that oxygen to them, they kind of in conjunction do the therapy. You want to give them the oxygen. You want to hydrate them. Why?
To
The cells
thin
are
it
not
out.
aggregating together. You want to hydrate them. But, so oxygen, you give them pain management. If the question addresses pain and it just screams out pain, what are you going to do? Give them pain management.
What do you do first, oxygen or
Okay,
PAN?
what does your stem say to you? If it says, all it says is the patient's in complete pain, they're talking to you, they're not short of breath, the management is pain. If they're short of breath, they're confused, what is it? But to tell you the truth, it's simultaneous. Okay. And with sickle cell, what organs become enlarged?
The spleen.
And sometimes they may have hepatomegaly, but mainly the spleen. Because the spleen regulates the production and the destruction of blood cells. Okay. Polycythemia, the blood is thick. Too many red blood cells. These individuals may need phlebotomy, removal of some blood. These aren't the people that you want them to eat liver and spinach. These people, they're putting out too much of the red blood cells. So that's anemia. Okay. And polycythemia. We're going to talk about leukemia and cancer. Thrombocytopenia. You're seeing me across the way. What would alert you to the fact that I might have thrombocytopenia? Or you bruising, the TPI. If you looked at my gums, would it be profuse or bleeding, or would it be just oozing?
Maybe bleeding.
Depending on the degree of the platelet increase. But if it's just increased, you might just have some real oozing. All right, hemophilia. They don't have factor VIII. Who's the problem, mom or dad?
Mom.
Mom. It's usually associated with mom and son. Factor VIII. Okay, Christmas disease we kind of touched on, but hemophilia, the problem comes in is you want to have these people avoid what?
Contact sports.
Contact sports. And if you need to do anything invasive, you see if there's an alternate route that you can get the same effect. These are the people that you want to have multiple IV sticks or multiple injections. Huh? Okay, she would make. You're a big girl here. Okay. She says, what if this person's a diabetic and you gotta do finger sticks all the time?
There's that new diabetic one you scan.
You can, so they would be a candidate for that, where you're not getting all that sticking of this person. Okay, PVD we talked about. How would you know by just looking at me, I'm up here, that I had PVD, peripheral vascular disease, arterial now. If I had an arterial problem, what might
Discoloration.
Huh?
Discoloration.
Discoloration, my discal area. If it's my legs, what might you notice about the hair?
No hair.
No hair or lack of hair. What would be my pulses? If it's arterial? Weak. Okay, what about my capillary field?
Slow.
Slow.
What about the temperature of my skin?
Cool.
Cool.
What might I say I sense even at rest?
Pain.
Aches, pain, maybe some paresthesia. That's arterial. On the venous side, what could you use to enhance circulation back to the heart? Plexi pulses, SCD. What if a person can't afford that? What could you have them put on? Ted hose. Do we leave Ted hose on all the time?
No.
No.
You take them off at night. Sets the skin.
Elevated too, right?
Deep vein thrombosis. So you're with the new grad, and the new grad says, I want to do a home sign. What do you say?
No.
Because what? They give your rationale for telling you.
Dislodge a clot.
Dislodge. She also says, oh, this person's having so much pain, and I want to soothe the skin. Another way of dislodging them. Clot. Person is started on an ID of what? Heparin. What's our goal as far as value of the PTT?
1.5 to 2.
The norm. Okay. This patient is placed on the fourth day, they're placed on Coumadin in conjunction with the heparin. What do you do?
Measure both levels.
Okay, let me put it this way. Patient says to you, why do I need 2 blood thinners? What is your rationale? Is it okay for them to have both at the same
Yes.
time?
They work different.
Yes, because they're going home on Coumadin. But you're tapering down the rate of heparin. They're started on Coumadin. What lab are you going to follow with Coumadin?
PT.
PINR. With the hopes that they will be therapeutic, 1.5 to the norm, and they're going home on Coumadin. What foods are you going to tell them to avoid relative to Coumadin?
Green leaf salads.
Foods that are high in what?
Vitamin K.
Okay. What is the antidote for Coumadin?
Vitamin K.
Vitamin K. What is the antidote for all right. Raymond, what precipitated this person? What things would you teach them to avoid so they don't go into Raymond?
Stress.
Stress,
Cold.
anything that causes vasoconstriction. Okay, someone has intermittent claudication, that is, they're in bed at night. What helps them get rid of the pain that they have at rest?
Dangling.
Dangling or stuff. Hypertension, it can be primary. That means that they inherited it, okay? And that's primary is the same as essential. Secondary can be due to systemic disorders, like for instance, congestive heart failure. It can be, and hypertension can aggravate the congestive heart failure. You're going to be talking about some endocrine disorders like hyperthyroidism. I'm just throwing this out. I'm just showing you the correlation. People who have renal disease, people who have pulmonary hypertension. So secondary means something else, some other disorder is causing. Person gets a single reading of blood pressure, and they say, "Do I have hypertension?" What you say?
Not necessarily.
They have a series at different times during the day, so that you do a little diary to see what their blood pressure is. What's the concern if someone has a blood pressure of 156 over 110? What's the issue?
The heart can't relax.
It can't relax. The diastolic is, and you're having that pulse pressure, the pressure is increased. Okay, the meds we talked about, all of those ones that Professor Bethune. And the key thing you need to remember is you need to tell the person to drive slowly because a lot of them cause the orthostatic hypotension. In conjunction with that, what dietary will we tell these people?
Cardiac.
Low sodium, low cholesterol. So think of some foods that are low in sodium. Think of a way if we ask a question, the person needs to be on a low sodium diet. Which of the following is the best choice? You're going to look at one that has low sodium and low cholesterol. Okay. What is the goal, overall arching goal, relative to hypertension recovery? What are we preventing?
Major organ damage.
Yeah, damage to major organs. We're trying to prevent CVA. We're trying to prevent renal insufficiency or end-stage renal or CVA. Okay, I want to go to this. If you know this little thing there, who's the universal recipient?
Oh.
Oh, who? Okay, who is universal donor?
Wait, no. O can't receive. You'll kill me if you give me A blood.
Okay, say it again. Who's the universal recipient?
AB.
AB who?
Positive.
Positive is dominant over everybody. Okay. Who's the universal donor?
Oh.
Oh, who?
Oh, no.
Oh, nay. Okay, so I'll have a scenario, a patient, is this blood type, and they're getting this blood. You need to tell me, is it safe for any question? You know these things. One thing about blood products is, I told you platelets are infused fast. I told you that an age group, the elderly, if you give the blood too fast, what might they go into? Heart line, congested, change. Okay. What med could you give if the person gets too much volume quickly? A diuretic. Okay. That is that. I know it's a lot, but you know, people, and it's now 11:22, but we had given you the correlation between, but ask yourself, what would help you demonstrate? What would be a problem with what they demonstrated? What would be the medications, we know the antidotes, and the meds that high progressive students presented them, and the math. My people, I have 2 more care plans that I need